Neuro-ophthalmolgy. Neuro-ophthalmology, first we will discuss about the lesions of visual pathway. Lesions of visual pathway. First, if the lesion is at the level of optic nerve, then there can be complete blindness in the affected eye, and there is loss of light reflex on the affected eye, and consensual light reflex is lost in the other eye. On the contralateral eye is lost. Then neuroflex will be present, and central or paracentral scotoma will be there. Scotoma. Other causes of optic nerve lesions include optic neuritis, optic atrophy, sarcoidosis, Leber's hereditary optic neuritis, or traumatic avulsion, traumatic optic neuritis. Okay. That is if the lesion is at the level of optic neuritis. Now, if the lesion is at the level of central chiasma, that is here central chiasma, then the patient will have bitemporal hemianopia. This is a bitemporal hemianopia, both sides. Bitemporal hemianopia, and there will be bitemporal hemianopic paralysis of pupillary reflex. Most common causes pituitary tumors. Other causes are supracellular aneurysm, craniopharyngioma, and glioma of third ventricle. Next, if the lesion is at the level of lateral chiasma, there will be binasal hemianopia. Binasal hemianopic pupillary paralysis will be also there. Paralysis of pupillary reflexes. Causes include distension of third ventricle, the side on either sides, distension of third ventricle, or edema of posterior communicating artery. Next, if the lesion is at the level of optic tract or lateral geniculate body, there will be incongruous contralateral homonymous hemianopia. Contralateral homonymous hemianopia, that is homonymous, like both side it is right side, here also it's right side, here also it's right side, both sides right side, hence homonymous. And then there will be contralateral wernickeous pupil because optic tract is involved. Causes include syphilitic meningitis, TB, tumors of optic thalamus. Optic radiations in temporal lobe involves the inferior fibers leading to superior quadrantic hemianopia, that is pie and sky appearance. Here normal pupillary erection will be there. Then this is a temporal lobe which involves the temporal lobe fibers which will correspond to the superior. Temporal lobe, which that is a inferior fibers will be involved, so the superior field of loss of vision, superior quadrantopia. Parietal lobe, superior fibers are involved, so there will be inferior quadrantic hemianopia. Then pie on the floor, also known as pie on the floor, there is normal pupillary action. Parietal lobe, superior fibers, inferior quadrantic hemianopia. Optic radiations will lead to homonymous hemianopia, the same side, right side of this side, right side of this side. Then anterior occipital visual cortex. This here is the tip of anterior occipital. It is due to the occlusion of posterior cerebral artery. Here, the posterior cerebral artery, the macula is represented in the posteriormost part or tip of occipital cortex, which is also supplied by the middle cerebral artery. So, in case of anterior occipital lobe, the posterior cerebral artery is involved. The macula will be spared. There will be sparing of macula, because macula is supplied by the middle cerebral artery. Here macula is also supplied by the middle cerebral artery, and so in case of it will result in congruous homonymous hemianopia, sparing macula. Towards the optic radiation, LGB and all, it will be homonymous hemianopia, and it will be more congruous towards occipital side. If tip of occipital cortex is involved, then there will be macular involvement, congruous homonymous macular defect. that is because of the middle cerebral artery is only involved. Next, coming to certain types like choroidic hemianopia, it is lesion in the occipital cortex involving involving the calcarine fissure. Then altitudinal hemianopia, loss of upper half of field is due to intra or extracellular tumor. Altitudinal hemianopia, involvement of loss of lower half of field. Lower half of field is due to supracellular tumor. Then optic atrophy, that is partial or descending, occurs in lesions of chiasmal lesion, optic tract lesion and geniculate body lesion. Optic atrophy doesn't occur in lesions of optic radiations and visual cortex. Now coming to occipital lobe visual cortex hemianopia, it is extremely congruous towards the as we go behind it will become extremely congruous. Then homogeneous density with sparing of macula will be seen. There is something called as redox phenomena, where only moving targets are perceived. Only moving targets are perceived within the defective visual field. Then Anton syndrome, denial of blindness, seen in occipital lobe visual cortex hemianopia. Redox phenomena, only moving targets are perceived within the defective visual field. Next we will discuss about pupillary pathway of light reflex. Now coming to see in visual pathway, from the optic nerve it goes to the optic chiasm. Here from optic nerve it goes to optic chiasm and then through the optic tract to lateral geniculate body. Here there is a lateral geniculate body. It ends up in lateral geniculate body and then goes to optic radiation and then to the occipital lobe. In pathway of pupillary light reflex, from optic nerve it goes to the optic chiasm. The fibers split to optic tract and then goes to pretectal nucleus. Some fibers go to lateral geniculate body, that forms a visual pathway. Those that goes to the pretectal nucleus forms a light reflex. From pretectal nucleus it synapse. Both the fibers cross to the Eddington-Westphal nucleus here. Both sides fibers will cross to the Eddington-Westphal nucleus. Then cross to the both Eddington-Westphal nuclei. From there which synapse there and travel via the cranial nerve third cranial nerve to the it goes to the subarachnoid space cavernous sinus, then travel in the inferior division of the cranial nerve third to the ciliary ganglion here, and from there the postganglionic fibers travel via short ciliary nerve to the sphincter pupillae. Sorry, in right reflex short ciliary nerves to the ciliary body and iris sphincter. That is a pupillary pathway of light reflex. Now the site of lesion based on then if the lesion is in the region of optic nerve, then we will have amerotic unilateral, the same side amerotic paralysis, that is absent light reflex. We will have absent light reflex on same side, and consensual light reflex will be absent on the contralateral side. Then in case of then it will come to middle chiasma, there will be bitomal hemianopia, lateral chiasma there will be binasal hemianopic paralysis. Then in case of optic tract lesion, it is known as contralateral hemianopic paralysis, it is known as Wernicke's reaction. Then if there is lesion of the proximal part of optic tract, then there will be normal pupillar reaction. If there is the lesion is at central decussation, then there will be bilateral reflex paralysis. That is here if the lesion is at here the decussation, here the lesion is at the level of decussation, then there will be bilateral reflex paralysis, that is known as Argyll-Robertson syndrome, Robertson pupil. between decussation and constrictor center. Here. Between the decussation and constriction center, if the lesion is here, this is the decussation, the constriction center is the vestibular here, then the lesion is known as there will be unilateral Argyll Robertson pupil. This will be bilateral. Next is extended nuclear or supranuclear. There will be ipsilateral absolute pupillary paralysis. And in case of third nerve, there will be again same ipsilateral pupillary paralysis. And in ciliary ganglion lesion, it is known as Adie's pupil. That is right reflex will be absent in here. Neuroflex will be present. Coming to abnormalities of pupillary reflexes one by one. First is hemerotic right reflex. Here there is absence of light reflex on the affected side. Light reflex is absent on the affected side. On that, then absence of concentral light reflex on the contralateral opposite side is also absent. Then the lesion on the optic nerve or retina is on the affected side, leading to complete blindness will be there. In diffuse illumination, both pupils will be of equal size. Equal size in diffuse illumination. It is usually due to optic nerve or retinal involvement on the affected side. Efferent pathway defect includes as there will be absence of both direct and consensual light reflex on the affected side. Direct light reflex and consensual light reflex will be absent. Neo right reflex will also be absent in efferent pathway defect. On the normal side, both direct and consensual right reflex will be present. Efferent pathway defect is a sphincter paralysis. Causes can be because of parasympatholytic drugs. Causes can be parasympatholytic drugs like atropine, homatropine, internal ophthalmoplegia, and third cranial nerve palsy. Next is vernix and hemianopic pupil. In vernix and hemianopic pupil, the lesion is at the site of optic tract. Lesion is at the region of optic tract. If light, now we know that both the temporal fibers remain uncrossed and the nasal fibers crosses. So when light reflex is absent, if light is thrown, if this is the side affected, when light is thrown on the temporal half of the affected side and on the nasal half or the retina on the normal side, then the light reflex will be absent. In these two sides, light reflex will be absent. Light reflex will be present if the light is thrown on the nasal side of the on the nasal half of the retina on the affected side and on the temporal half of the retina on normal side, because of the decussation of fibers. That is vernix hemianopic pupil, where the lesion is at the level of optic tract. Now coming to Marcus gun pupil, it is also otherwise known as relative efferent pupillary defect. So here a bright flash of light is thrown onto one eye and pupillary constriction is noted. Then the light is quickly moved to the opposite eye and response is noted. The swinging to and fro of flashlight is repeated several times. Normally both pupils constrict equally and the pupil to which light is transferred also remains constricted. In presence of RAPD in one eye, the affected pupil will dilate when the flash of light is moved from the normal eye to the abnormal eye. The response is also called as Marcus gun pupil, which is the earliest feature of optic nerve deficiencies. Seen in optic neuritis, optic atrophy, CRAO, CRVO and retinal detachment. that is Marcus Gunn pupil. Next is Argyll-Robertson pupil. In Argyll-Robertson pupil, here you can remember, as the name suggests, accommodation reflex is present, and pupillary reflex, reverse, where pupillary reflex is absent. It is commonly seen in neurosyphilis, also seen in other conditions like multiple sclerosis, polio, encephalitis, diabetes mellitus. Here the lesion is at the level of tectum. See, here you can see the pupillary fibers, the lateral, the visual pathway fibers going to the lateral geniculate body, and the pupillary fibers going to the pretectal nucleus. This is a pretectal nucleus here, and this is the Eddington-Westphal nucleus. The lesion is at the level of tectum. So that is the internuncial fibers between the pretectal nucleus and the Eddington-Westphal nucleus at the level of pretectum. Here pupils dilate very poorly and with mydriatics, but constricts with serine. Okay. Next is Holmes-Atis tonic pupil. Holmes-Atis tonic pupil. Here light reflex is absent, then near reflex is slow and tonic. Affected pupil is large, anisocoria, here the ciliary ganglion is affected, so there is no parasympathetic action. Affected pupil is larger, there will be anisocoria. Okay, there is difference in the size of the pupil caused by postganglionic parasympathetic pupillomotor damage, usually unilateral and associated with absent knee jerk. It is usually seen in healthy young females, women, diabetes mellitus, amyloidosis, shy tracker syndrome. Usually Atis pupil doesn't normal pupil doesn't constrict with 0.125% of that is diluted percentage of pilocarpine, whereas Atis pupil will constrict with 0.125% of pilocarpine because of hyperinnervation, denervation, hypersensitivity. Pupil dilates with mydriatics. Here this in Atis tonis people, the defect is at this level, postganglionic parasympathetic pupillomotor damage. So both light reflexes happen and near reflex is slow and tonic. Affected pupil is larger because this parasympathetic activity is not there, constriction is not there. Next optic neuritis. Coming to etiology, demyelinating diseases are the most common causes of optic neuritis, which include multiple sclerosis, neuromyelitis optica of David disease, diffuse periaxial encephalitis of Schilder. These are the some diseases. Hereditary optic neuritis can be there. Optic neuritis in case of Leber's disease. Then para-infectious optic neuritis. Measles, mumps, chicken pox, whooping cough, glandular fever, immunization, or infectious like ethmoiditis, cat scratch fever, syphilis, Lyme disease, cryptococcal meningitis, and AIDS, etc. Symptoms include the hallmark is a sudden progressive visual loss that can be subtle or profound, deteriorating over hours to days. Sudden progressive visual loss. Visual obscuration of bright light is a typical symptom of bright light, that is a typical symptom. Delayed dark adaptation can be seen. Delayed dark adaptation. Impaired color vision, typically red desaturation, because optic nerve is affected, red desaturation is seen. Movement phosphenes and sound induced phosphenes, that is glowing sensation produced by non-photic or inadequate stimuli can be seen. These are the complaints. Then Uthos phenomena, it is episodic or transient loss of vision on exposure to heat, or which recovers on rest or moving away from the heat. Then there is Pulfrich phenomena known as that is impaired depth perception. Which is seen in optic neuritis. Then pain on movement of the eyeball is a hallmark of retrobulbar neuritis, then papillitis. Deep orbital retroocular or brow pain, which is usually aggravated by eye movement, that is increased by pressure on the globe. Then tenderness of the eyeball on digital pressure. It is present only in the early stages and disappears in few days. Signs include Marcus gun pupil. Then ophthalmoscopic signs include there can be in a retrobulbar neuritis, the optic disc will be normal, that is it is behind the optic disc. Behind the retrobulbar neuritis, optic disc will be normal. In papillitis, optic nerve head is affected, and in neuroretinitis along with adjacent macula is also affected. So in retrobulbar neuritis, optic disc is usually normal. In papillitis, there will be hyperemia of the optic disc. See here you can see there is hyperemia of the optic disc. Along with peripapillitis, with or without these flame shaped hemorrhages will be there, and blurring of disc margins can be seen. The disc margin is not made out, blurring of disc margin can be seen. Edema of the disc and obliteration of the physiological cup is also seen. That is in papillitis. Here again hyperemia of the disc, blurring of disc margin, few retinal hemorrhages etc. can be seen. Then in neuroretinitis, there is this particular stellate pattern of retinal exudation. This is known as a macular star. This is seen in macular star is seen in neuroretinitis. The fundus appears normal except for temporal pallor in few cases of retrobulbar neuritis. Most of the cases it is normal. In few cases there will be temporal pallor. Most common visual field defect is relative central or central cecal scotoma because of optic nerve involvement. That is the most common visual field defect. A visually evoked response, it shows decreased amplitude and delay in transmission time. Because of the involvement of optic nerve. Now evolution, recovery and complications, like visual acuity and color vision is lost progressively over. Color vision and visual acuity is lost progressively over 2 to 5 days. A gradual recovery of visual acuity with time is characteristic. All the permanent residual visual defects in color vision and contrast, brightness and sensitivity are common. Contrast, brightness, sensitivity are common. Treatment includes, as of now there is no effective treatment. Corticosteroid therapy may shorten the period of visual loss. Visual loss, that period is shortened but will not influence the ultimate visual recovery. Then all patients with acute optic neuritis should have a brain MRI scan. If scan is suggestive of multiple sclerosis, then IV methylprednisolone for 3 days is given, followed by oral prednisolone for next 11 days and taper prednisolone for 4 days. This therapy will delay conversion to clinical multiple sclerosis over the next 2 years. Oral prednisolone therapy is contraindicated when given alone. Okay. Now optic nerve disease and macular disease is a gross differentiation. In optic nerve disease, pain is a common feature. In macular disease it is rare. RAPD is present in optic nerve disease, whereas in macular disease it is absent. Dyschromatopsia is present in optic nerve disease, and metamorphopsia is usually seen in macular disease. Brightness sense is reduced in optic nerve disease. Sense is augmented in macular disease. Next is toxic or nutritional neuropathy or toxic amblyopia. Toxic neuropathy, nutritional neuropathy or toxic amblyopia. It is coming to nutritional optic neuropathy. Here deficiency in B complex vitamin including B1 thiamine, B2 riboflavin, B12 cobalamin and folate are the most common implicated nutritional deficiency leading to nutritional optic neuropathy. Administration of vitamin B1, B6 and B12 may give good result. Tobacco amblyopia. It is seen in men who are pipe smokers, heavy drinkers with deficiency of proteins and vitamin B complex. Basically pipe smokers and heavy drinkers who have deficiency of proteins and vitamin B complex. Cyanide in tobacco causes degeneration of the ganglion cells in the macular region, and the patient usually complains of bilateral progressive central visual loss. Visual field examination, there will be central cecal scotoma here. Central cecal scotomas can be seen. Defect is greater for red. Then treatment is complete cessation of alcohol and consumption and tobacco consumption. Hydroxycobalamin can be given. Next is methyl alcohol amblyopia. Here it can be acute amblyopia. It is an acute amblyopia. Ethyl alcohol can causes chronic amblyopia. Ethyl alcohol causes chronic amblyopia and acute amblyopia. Methyl alcohol causes acute amblyopia. Complete blindness in 2 to 3 days will be seen. There will be bilateral optic atrophy, and blindness is due to degeneration of the ganglion cells in methyl alcohol amblyopia. Now next coming to Leber's hereditary optic neuropathy. Leber hereditary optic neuropathy. It is caused by maternally inherited mitochondrial DNA point mutations. Typically affects male between the age of 15 to 35 years. Atypical cases the condition may affect females and present at any age between 10 to 60 years. Typically acute or subacute, bilateral, severe, painless loss of central vision will be patient will complain of. The papillomacular bundle. The papillomacular bundle. This is the optic disc. This is the papillomacular bundle. These are the is particularly affected. Papillomacular bundle. FFA, there is no leakage. There is no leakage in FFA from the disc or microangiopathic vessels. Here, typically the signs we can see this disc hyperemia and dilated capillaries can be seen. Telangiectatic microangiopathy, vascular tortuosity and swelling of the peripapillary nerve fiber layer can be seen. Subsequently, bilateral optic atrophy will be there. But even though there is the disc hyperemia, telangiectatic vessels and tortuous vessels, there in FFA there is no leakage from the disc or these microangiopathic vessels. That is Leber's. Next is anterior ischemic optic neuropathy, that is AION. It can be either arteriatic or non-arteriatic. First one is arteriatic AION. Now it is due to arteriatic AION is due to the inflammatory and thrombotic occlusion of the short posterior ciliary artery. These are the short posterior ciliary artery which arises from the central retinal artery, which is caused by giant cell arteritis. Inflammation and thrombotic occlusion of short posterior ciliary arteries caused by short posterior ciliary arteries affected here caused by giant cell arteritis, usually seen in old patients. Mean age is 70 years. More common in females. Systemic features: the patient will complain of headache, tenderness, of temporal arteritis, temporal arteries, jaw claudication. There will be patient will complain of transient ischemic attacks, CRAO, diplopia can also be there. Then sudden marked visual loss the patient will complain of sudden marked visual loss. And RAPD will be present. In case of arteritic AION, optic disc, it will be pale and edematous. You can see here it is pale and edematous optic disc. FFA, there will be delayed choroidal filling. This is a differentiating factor from NION. See here, the short posterior ciliary is affected. There will be delayed choroidal filling. In arteritic, visual fields, there will be altitudinal hemianopia, commonly involving the inferior half. That is visual field examination. There will be increased ESR and CRP, C-reactive protein. A non-arteritic AION, it is most common type of AION than arteritic. Risk factors include crowding of disc with small cup, cataract surgery, hypertension, diabetes mellitus, smoking, hyperlipidemia. These are the risk factors for non-arteritic. Mean age is again 60 years old age. Male and female are equally affected. Males and female are equally affected. Relatively less marked visual loss as compared to arteritic. Less marked visual loss. Optic disc is hyperemic and edematous, and FFA there is only disc delay. In AION, this arteritic, there is both disc and choroid delay. Here only disc delay is there. This is the hyperemic and edematous disc in non-arteritic. Next, this differentiating factor also you should remember. In FFA or in non-arthritic there is only disc delay. In arthritic AIN there is both disc delay and choroidal delay. Next, coming to optic atrophy. Optic atrophy classification is based on ophthalmoscopic appearance. First is primary optic atrophy. Primary optic atrophy, the lesion is proximal to the optic disc without any antecedent papilledema. There is no long-standing papilledema, no other causes of optic atrophy. That is when we call primary optic atrophy. Causes include multiple sclerosis, retrobulbar neuritis, Leber's hereditary optic neuropathy, toxic amblyopia, then tapes dorsalis. Here the characteristics, the disc will be chalky white disc. Reduction in the number of small blood vessels can be seen in the disc. Normally there will be blood vessels on the disc surface. Here there will be reduction in the blood vessels. This is known as Kestenbaum sign. Edges of the disc are sharply outlined. There is no any other previous cause, no long-standing cause, so the edges will be sharply outlined, and the lamina cribrosa seen clearly at the bottom of the, there will be these black dots which will be seen at the bottom of the physiological club. Major retinal vessels and the surrounding area of the retina will be normal in case of primary optic atrophy. Now next is secondary optic atrophy. Secondary optic atrophy is sequelae of a long-standing papilledema or papillitis. Then the optic disc is dirty white, and the edges are blurred due to gliosis. Optic disc is dirty white, edges are blurred due to gliosis, and physiological club is obliterated here, and the lamina cribrosa is not visible. Next, coming to consecutive optic atrophy. Consecutive optic atrophy, here there is it is following destruction of the ganglion cells. Secondary to lesions of the choroid or retina. It will be secondary to lesion of the choroid or retina. There is destruction of ganglion cell. The causes include chorioretinitis, retinal pigmentosa, pathological myopia, CRIO. There is yellow waxy optic disc, and the retinal vessels are attenuated. So basically there is a primary optic atrophy, secondary and consecutive. In primary optic atrophy, this primary optic atrophy occurs without swelling, without antecedent swelling of optic disc. The cause of primary optic atrophy include tumors compressing optic nerve, retrobulbar neuritis, hereditary optic neuropathy, etc. Fundus picture. There is pale optic disc with clear delineated disc margin. Then Kestenbaum index is there. Kestenbaum index sign, the reduction in the number of small blood vessels. Reduction in the number of small blood vessels on the optic disc. Then the surrounding normal retinal vessels and surrounding retina will be present. In case of secondary optic atrophy, which is due to antecedent swelling of the optic disc, common causes are, we discussed, papilledema, papillitis, anti-ischemic optic neuropathy, etc. Fundus picture, there will be a dirty white optic disc with poorly delineated margins of the optic disc due to excessive gliosis, and attenuation of the retinal vessels and perivascular sheathing will be seen. Consecutive optic atrophy occurs due to degenerative inflammatory vascular lesions of the surrounding retina. The cause include central retinal artery occlusion, central retinal vein occlusion, retinitis pigmentosa, pathological myopia, etc. Fundus picture include will show this yellow waxy optic disc, and surrounding retina the causative disease, example retinitis pigmentosa, will be seen. Next, papilledema. The clinical features of optic atrophy includes vision loss, that is sudden or gradual, partial or complete will be there. Sudden or gradual, partial or complete. Pupil, it can be semi-dilated, sluggish or absent reflex. RAPD can be present, and ophthalmoscopy, pallor of the disc. The features the discussed now will be there. Papilledema. Next, papilledema. Papilledema is edema of the optic disc, optic nerve head, optic disc or optic nerve head associated with increased intracranial pressure. It is almost always bilateral, though it may be asymmetrical, but it is almost always bilateral. Can be asymmetrical but bilateral. Causes include the cause of raised artery and bilateral papilledema. Other causes: intracranial space occupying lesions like brain tumor, abscess, aneurysms, tuberculoma, etc. Intracranial space occupying lesions in any position except medulla oblongata induce papilledema. Papilledema is most frequently associated with posterior fossa tumors. Okay, papilledema is least associated with pituitary tumors. Least associated with pituitary tumors. Intracranial space occupying lesions of the cerebellum, midbrain, parieto-occipital region produce papilledema more rapidly and acutely than lesions of other areas. These produce papilledema more rapidly. The site of tumor is more important. Site is more important than its nature, size or rate of growth. Other causes of other than intracranial space occupying lesions, other causes of papilledema include meningitis, encephalitis, or intracranial hemorrhages. Then obstruction of CSF due to damaged arachnoid villi, or pseudotumor or idiopathic intracranial hypertension. Then malignant hypertension or cerebral edema. Now there is raised ICT and unilateral papilledema. See, there is something called Foster-Kennedy syndrome. It is associated with olfactory groove or sphenoidal meningioma. Frontal lobe, also there can be frontal lobe also due to frontal lobe tumors and tumors of pituitary body. It is that pressure optic atrophy on the side of the lesion. There will be optic atrophy on the side of the lesion, pressure optic atrophy, and papilledema on the other side with ipsilateral anosmia. That is Foster-Kennedy syndrome. That is optic atrophy on the side of lesion and papilledema on the other side. Then there is pseudo Foster-Kennedy syndrome. That is papilledema associated with increased intracranial pressure on one side with pre-existing optic atrophy on other side. That is pseudo Foster-Kennedy syndrome. Now pathogenesis here is theory, that is papilledema here. The papilledema develops as a result of stasis of exoplasm in the prelaminar region of the optic disc due to alteration in the pressure gradient across the lamina cribrosa. That is known as Eyre theory. Now, clinical features of papilledema include amaurosis fugax, that is the most common. Amaurosis fugax, there is recurrent attack of transient blurring of vision. Visual acuity and pupillary reaction remain normal until late stages in case of papilledema, and it can be divided into early, established, chronic and atrophic. In early or incipient papilledema, the visual acuity and pupillary reactions are reaction to light is normal. Pupillar reactions are normal. In early papilledema, there is obscuration of the margins. Obscuration or blurring of disc margin is the first sign. Nasal margins are the first involved in case of followed by superior, inferior and temporal. Obscuration or blurring of disc margin is the first sign. Nasal margins is first involved, followed by superior, then inferior and temporal. Then absence of spontaneous venous pulsation at the disc will be present, and splinter hemorrhages can be seen in peripapillary areas. Splinter hemorrhages in peripapillary region. This here is grade 1. A C-shaped halo is seen usually in the nasal region. Then established a fully papilledema, fully established papilledema, fully developed papilledema, established or fully developed papilledema is there. Next stage, there is apparent optic disc edema in this stage. There is optic disc edema with obliteration of the physiological cup. Physiological cup obliteration. There is marked hyperemia of the disc. Here you can see marked hyperemia of the disc, and there is multiple cotton wool spots you can be seen. That is infarcts of the nerve fiber layer. Cotton wool spots are nothing but infarcts of the nerve fiber layer. These multiple cotton wool spots can be seen, and superficial hemorrhages can also be seen near to the disc. Veins become tortuous and engorged, and radiating edematous falls around the macula. Macular star can also be seen, and enlargement of the blind spot. Enlargement of the blind spot is seen in visual field. That is established papilledema. Marked hyperemia disc, multiple cotton wool spot, macular star, and enlargement of blind spot will be seen. In chronic or long-standing with that papilledema, that is visual acuity depends on the duration of papilledema in this case, and pupillary reactions are still normal. There is something called a champagne cork that is seen in chronic papilledema. Champagne cork like optic disc, and small drusen like deposits on the disc surface can be seen. That is known as corpora amylaceae. Those are drusen like deposits on the optic disc, crystalline deposits on the optic disc surface in chronic or long-standing cases, and enlargement of blind spot will be seen. This is the champagne cork appearance of the optic disc seen in chronic or long-standing papilledema. Then the last stage is the atrophic papilledema. Here the patient will have impaired visual acuity. It is in this stage the patient will complain of decreased vision, and light reflex will be impaired. In atrophic papilledema, there is greyish white discoloration and pallor of the disc due to atrophy of the neurons and associated gliosis. Concentric contraction of the peripheral field of vision will be also there in visual field analysis. There is greyish white discoloration and pallor of optic disc can be seen due to atrophy of neuron and associated gliosis. In peripheral field analysis, contraction of the peripheral field of vision will be seen. Next, coming to color blindness, we will discuss a little bit about color blindness. See, color blindness, it is an individual with normal color vision. Normal color vision is known as trichromate. Individual with normal color vision is known as trichromate. In congenital color blindness, males are affected more. There is dyschromatopsia. Dyschromatopsia can be anomalous trichromatic color vision, dichromatic or blue chrome. Dyschromatopsia in an anomalous trichromatic color vision, that is mechanism to appreciate all three primary colors is present but defective for one or two of them. It is defective. If one can appreciate all three primary colors, but it is defective. If it is defective for red color, then it is known as proto-anomalous. If it is defective for blue color, then it is known as, if it is defective for green color, it is known as deuteranomalous. Then if it is defective for blue color, it is known as tritoanomalous. Anomalous, it is defective. Then we have dichromatic color vision. That is faculty to perceive one of the three primary colors. One of the three primary colors is completely absent. They are dichromates. Okay. Protoanopias. Okay. That is complete red color defect. Deuteranopia, that is complete green color defect. Tritanopia, that is complete blue color defect. Then there is blue cone monochromatism. That is complete absence of red and green cone function. Is completely absent. The patient will have poor day vision but normal night vision. That is in blue cone monochromatism. And the color vision is severely limited. Only difference in blue hues are detectable. Then there will be reduced visual acuity and small amplitude nystagmus will be there. And photosensitivity will also be there. In achromatopsia, there is rod monochromatism. Rod monochromatism, that is total color blindness. Patient will have day blindness, nystagmus with normal fundus. Again, coming to acquired color blindness, it is either due to damage to macula or optic nerve. Blue-yellow impairment is usually seen in retinal lesions. Central serous retinopathy, retinal affected condition, like especially macula region, CSR, macular edema, shallow RD, shallow retinal detachment. Red-green deficiencies is usually seen in case of optic nerve lesion, like Leber's hereditary optic neuropathy or optic nerve compressions. In those cases, acquired blue color defect is usually seen in old age. Increased due to nuclear sclerosis of the crystalline lens, acquired blue color defect can be seen. Now coming next is night blindness or nyctalopia. Night vision, that is scotopic vision, is a function of rods. Night vision. So function of rods. The causes can include vitamin A deficiency, retinitis pigmentosa, congenital high myopia, familial or paracentral lenticular or corneal opicities or Oguchi's disease can be there. Next is day blindness. Day blindness or hemerotopia. There is congenital deficiency of cones in here. Then there will be the central corneal, they can be associated with central corneal opicities and central lenticular opacities, that is polar cataract. That is day blindness. Next, just parts of optic nerve you should know. Parts of optic nerve. There is intraocular part here. There is intraocular part and intraorbital, intracanalicular and intracranial part. This is 1 mm, 25 mm, 5 to 9, 10 to 16. You can remember it as 1, 5, 3, 4, like square, like that you can remember. This measurements you should know. Intraocular part is 1 mm, intraorbital part 25 to 30 mm, intracanalicular 5 to 9, intracranial 10 to 16. This 5 square, 3 square, 4 square, like that you can remember if you want. Okay.